Faneuil Hall in Boston, the advocates. Tonight's question: should the federal government guarantee comprehensive medical care for all Americans? Arguing in favor is Patricia Butler, attorney and specialist in health law and health facilities policy. Appearing as witnesses for Ms. Butler are Max Fine, executive director of the Committee for National Health Insurance, and Bert Seidman, economist and director of the AFL-CIO Department of Social Security. Arguing against the proposal is William Rusher, publisher of the National Review. Appearing as witnesses for Mr. Rusher are Congressman Philip Crane, a Republican from Illinois and a member of the House Ways and Means Subcommittee on Health, and Walter McClure, a health policy analyst.
Good evening and welcome to the Advocates. The question of national health insurance invites that classic confrontation between those who would have the federal government control a vital industry and those who believe that private enterprise will always deliver a better product at a better price. The product, health care, how we provide it and how we pay for it. Almost every industrialized country has health care provided or at least paid for by the central government. In the United States, we rely heavily on private insurance, and millions of Americans have little or no insurance. Advocate Patricia Butler, a lawyer with the Colorado Department of Health, says we should have a national comprehensive health insurance plan in this country.
Our healthcare industry is not healthy. Only national health insurance will give us the security, the economy, and the high quality of medical care that we so obviously need. With me tonight to present the case for national health insurance are Mr. Max Fine and Mr. Bert Seidman.
Thank you. William Rusher, publisher of the National Review, says no.
The Kennedy-Corman Bill would turn over the control of medical care in America to the same government that gave us the Postal Service, Amtrak, and the swine flu program. and make us pay for it the way we pay for Social Security, by an ever-increasing payroll tax backed by a general increase in the income taxes of everybody still healthy enough to work. With me tonight to oppose this grotesque plan and incidentally to discuss some better ways of controlling medical costs are Mr. Walter McClure and Congressman Philip Crane.
Thank you, Mr. Rusher. We'll be back to both advocates in a moment for their cases, but first a word of background. The basic problem in the United States seems to be that we Americans pay a tremendous amount of money, more than anyone else in the world, for medical insurance, for medical services, which according to the statistics are far from the best in the world. Some people are disturbed by the statistics. For example, the World Health Organization says that we rank 10th in life expectancy, 15th in combating infant mortality. Thousands of American children die each year from preventable disease. Healthcare services are unevenly distributed around the country, and the price of these services is skyrocketing. If you've been in a hospital during the past few years, you'll have felt the effect of costs which have risen 13-fold since 1950, or twice the rate of increase in the cost of living. In 1976, we spent $140 billion on medical care, almost 9% of our gross national product, more than half than we spent on national defense. For many years, there have been proposals to reform the healthcare system in this country. They range from a proposal for a national health service like Great Britain's to one from the usually conservative American Medical Association suggesting tax credits to encourage people to buy private health insurance. President Carter is expected to offer his ideas on how health care should be improved sometime this spring. The proposal we're debating tonight is embodied in a bill sponsored by Senator Edward Kennedy of Massachusetts and Congressman James Corman of California. Here's what the bill would do. First, the federal government would pay for almost all medical services, and second, the government would set rates of payments for these services, including doctors' fees and hospitals. Proponents say that only through this kind of dramatic federal intervention can Americans be guaranteed reasonable access to quality medical care at a price the country can afford. Opponents say it would drive down the quality of medical care and drive up the costs. And so tonight's question: should the federal government guarantee comprehensive medical care for all Americans? Ms. Butler, the floor is yours.
Our doctors literally work miracles, but neither they nor we have bothered to control the shocking costs of health care. Costs so high that some hospitals charge $300 a day just for routine services. Costs so high that they bankrupt the poor, the elderly, and even the fully employed who, until serious illness strikes, think that because they've paid high premiums, they have enough insurance. We pay hundreds of billions of dollars every year. This year, over $800 for every man, woman, and child in the country to a wasteful, inefficient healthcare industry, an industry that cannot even guarantee us a doctor when we need one. This folly must end. We must make our healthcare system more truly democratic, more economical, and certainly more humane. The Kennedy-Corman proposal will do this. High-quality, low-cost healthcare is a right. The Kennedy-Corman proposal will guarantee that right to everyone. I call to the stand my first witness, Mr. Max Fine.
Welcome to the advocacy.
Mr. Fine has served with the Social Security Administration and the U.S. Public Health Service. He is currently the Executive Director of the Committee for National Health Insurance. Mr. Fine, for the past 9 years, you've worked for the adoption of national health insurance. Why do you support such a program?
Because I believe that health care is a basic human right. I believe that the working people of America and the poor and the deprived are entitled to the adequate health care that they need. I also believe that we have a system now which is overly costly, it's wasteful. We have some of the finest physicians in the world, some of the finest institutions, but the services are disorganized, the system is run in a very unbusinesslike way, costs are going right through the roof, and I believe that the properly constructed national health insurance program can implement the principle of health care as a right and can correct many of these problems in the health care system.
But don't many people in this country already have health insurance?
Yes, but it's like a dog's breakfast. It's all over the place. Some people have very good coverage. Other people have buffalo policies that only cover you when you're run over by a herd of buffaloes on Main Street. And in between, there are all kinds of variations, thousands and thousands of different types of policies, all for the same services. The bottom line is that all of the health insurance, all of the private health insurance that all of us have, covers only about 1/3 of the health care costs.
And are you suggesting that catastrophic illness also bankrupts some individual families?
It certainly does. We know that every day in the papers, or wherever I go, there just seems to be a story that day in the paper about another family being driven right over the hill by medical costs. Catastrophic illness can be an ordinary illness because of the high cost of hospitalization.
And what's the cost to the average American for health care?
Well, as you say, it's about $800 per person right now. We pay it as taxpayers, we pay it as premium payers, and we pay it directly out of our own pockets for the services that the health insurance we have does not cover.
How have medical costs risen in the last few years, and why have they risen so fast?
Well, they've gone right through the ceiling. They've escalated much faster than other costs. Hospital costs lead all other costs in the Consumer Price Index. Health costs have escalated about twice as fast as other costs. And the reason why is that it's a unique industry. The hospitals are paid on a cost basis. That means that whatever cost they run up, we pay them. Physicians negotiate only with themselves how much they're going to be paid. You'd like to negotiate with yourself, and I would too, but if we did, we might pay ourselves more than we should be earning.
So we're spending hundreds of billions of dollars on our medical care. Does this enormous expenditure give everyone the care that he or she needs?
No. The federal figures show that there are 30 million people who have no access to health care in this country. There are many others who have limited access. They might have services when they get very sick. But for example, 40% of the preschool children in this country are not immunized against polio. There are many women who are not seen in the first trimester of pregnancy. The result is that a great deal of unnecessary mental and physical illness occurs.
And is it difficult to get a family doctor when you need one?
I'll say it is. We have far fewer family doctors today than we had during the Depression. Doctors are all super specialists.
All right, now we'll go to Mr. Rusher for some questions from Mr. Fine.
Mr. Fine, let me see if we can understand a little more precisely how the major provisions of the bill will work. As I understand it, doctors and hospitals would be reimbursed for costs of approved or common medical care. Is that correct?
There would be negotiations with the hospitals and with the doctors. Just as we have to have a family budget and live within those means, they would have to live within the means of a
But the reimbursement would be for specific types of approved care. Is that correct?
No, it would be for care that the doctor decides is necessary.
Well, that's what I'm getting. Suppose we have a type of therapy that a doctor wants to try out which has not been tried before.
Well,
how then, as I understand it now, having read the bill, the reimbursement cannot come to him or to the hospital for that particular kind of therapy, even though he and the patient both want it, unless it is a medically approved therapy approved by the board in Washington.
The doctor determines what type of medical care he wants to provide for the patient. If we're talking about a medicine, of course we're talking about a medicine that would be an approved medicine.
Approved by whom?
By the same system that we have now for approving medicine.
The medical profession itself, or a board in Washington?
They're involved in the approval of medicine.
Wouldn't the board in Washington, under the plan, the board established by the plan, have to approve the medicines too, though?
In the same sense that the FDA...
Yes. In precisely the same sense that the FDA does.
In the same sense.
Now suppose, and precisely what I'm asking you, sir, suppose that this is a medicine or a treatment or a course of treatments that the FDA or its equivalent, this new board, hasn't approved.
Well, the FDA does not approve treatments. They approve medicines.
No, but this board would approve treatments and medicines.
No, this board would not.
Well, then if you want to confine it to medicines, let's confine it to that.
I don't want to confine it to medicine.
I would like to, if you don't mind.
Treatment.
Tell me what would happen if a doctor and a patient agreed on a new medicine that was not yet approved by the board that this bill would set up in Washington.
Well, we would hope that the doctor would not prescribe that medicine to the patient.
Why? Shouldn't, my heavens, there are new drugs coming on the market all the time, are there not?
Well, a lot of people think that Laetrile is efficacious,
well, yes.
and most don't.
Oh, yes. Laetrile is an example of one that has had heavy criticism. But what about types of medicines that are widely used in other parts of the world that might save lives here? What I'm getting at, Mr. Fine, is simply whether or not the decision of a doctor and a patient is determinative in these cases. And the answer, I take it, is that no, it has to be made and approved by a board in Washington.
In terms of medicine, yes. Not in terms of the physician's treatment of the patient.
And if the board in Washington hasn't been told by enough Canadian mice that this particular drug is all right, then the drug doesn't get used, even though both the doctor and the patient want the drug or the treatment in question.
Well, that isn't exactly what this program is all about, because this one would create innovations in treatment. We think that there's been a stifling under the present system of innovation.
I think you just told me that innovation would not be permitted, that it would only be approved for. Well, let's try another question. Under the Kennedy-Corman Bill, would a doctor with 5 years' experience get the same pay as one with 20?
Not necessarily. The physicians themselves would determine that on a local basis.
Surely they'd have to negotiate with you, wouldn't they, with the board?
There would be a sum of money negotiated within the community for physicians' payments. But within that community, the physicians would set relative value schedules.
And what about a good doctor with the same amount of years' experience?
Most doctors are very good.
I know, but suppose we have a good doctor and a less good doctor.
Yes.
Would they get paid the same?
That's up to the local medical society.
Oh, it's up to the local medical society.
That's right, or the medical foundation.
Do you really believe that the local medical societies of this country should have the kind of power to decide that question?
I believe that the medical profession, by and large, in this country measures up to very high standards. What we're interested in is making the entire profession, giving them the opportunity to meet the standards of the very best.
I suggest to you that what you've described is putting immense new powers into the hands of the bureaucracy of the American Medical Association, Mr. Fine. You are going to let local medical societies determine the pay of doctors based upon whether or not, in the opinion of that society, they are good or bad, and whether the patient thinks they are bad or good or not.
Within a predetermined overall budget, within that community and nationally, there would be relative value fees set for physicians who might be boarded, and they would be
I have to
hired.
interrupt Mr. Rusher, excuse me. Ms. Butler, one more question.
Yes. Mr. Fine, you've described some shocking problems to us tonight. What would be the principles of a national health insurance program that would deal with these problems?
Well, in the first place, everybody would be covered automatically. If you lived in this country, you would be covered. There would be no conditions. If you need medical care, you get the medical care. In the second place, the Health Security Program and the National Health Insurance principles that we support would create basic reforms in the health care system, relying very much through incentives on the development of prepaid group practice plans and health maintenance organizations.
Excuse me, before we go to Mr. Rusher, I'd like to get one thing clarified from your earlier statement. If a new medical treatment were established, for example, a doctor wanted to try a new form of X-ray treatment, would there be a requirement that a board in Washington approve it and set a fee for it before that could be done?
Absolutely not.
All right. I was left a little confused by the former cross-examination.
And the confusion is partly in the law, which is extremely obscure about some of these things. Do I have a question?
Yes, your question, Mr.
ask now? Mr. Fine, is it important to you that the consumers, in this case the patients, should have some choice in these matters?
Yes, I believe that
And yet they do not have, in this case, the choice of what they are going to pay for a doctor that they want, do they?
Yes,
this is
they
left
do
to
have.
a local medical society, I believe
If
you
you'll
said.
permit me to answer the question,
Please do.
we're interested in creating more choices. Today, consumers do not have a choice of a family health care plan and health maintenance organization. Their choice today is pretty much limited to fee-for-service solo practicing physicians.
Thank you. Mr. Fine, thank you for joining us on
Thank
The
you.
Advocate. Ms. Butler?
We all need protection against ruinous medical bills. The healthcare industry needs a lid on inflation, and our democracy needs to guarantee equitable services to all. To show us the intelligent way that the Kennedy-Corman proposal will meet these needs, I call to the stand my next witness, Mr. Bert Seidman.
Mr. Seidman, welcome to The Advocate.
Mr. Seidman is an economist, a member of the President's Advisory Committee on National Health Insurance, and director of the Department of Social Security of the AFL-CIO. Mr. Seidman, under Kennedy-Corman, what would we get now that most of us don't have or can't afford?
Well, what we would get is a universal, comprehensive national health insurance which would make health care the right of every American. Specifically, they would have available to them physician services in the doctor's office, necessary in the home, although that's quite rare these days, or in the hospital, surgery or other types of care in the hospital. And also coverage for the very expensive kinds of diseases which are sometimes called catastrophic.
Any other kind of benefits?
Yes, as time goes on, there would be dental benefits, probably starting with the children, mental health care, nursing home care, and other kinds of long-term care. But these things might not be in the program at the very beginning.
This sounds a lot like socialized medicine, like they have in England.
No, it is not socialized medicine at all. Socialized medicine, as in England, for example, involves the government owning the hospitals, and most of the doctors are employed by the government. That's not the program that we want at all. We want a program of national health insurance, which is quite different from the National Health Service that they have in England.
Under this proposal, most funds would be channeled through the federal government to administer the program. Why is this a preferable way of financing medical care than what we have now?
It's a preferable way because the system that we have now involves fragmented financing. We have hundreds of insurance companies with many different kinds of policies, and they're in no position to hold down the costs of care or assure the quality of care, and they have not done so. The record proves this.
Then how would the Kennedy-Corman plan help to control medical costs?
It would do this because the financing of the program would be from a single source, and in a democratic country, the single source should be the federal government, either financing the program or controlling the financing of the program. And it would be in a position, as Mr. Fine said, to negotiate with the doctors and with the hospitals so as to hold down the cost and to encourage the improvement of the quality of care.
Give us some examples of the types of controls that would be imposed.
On the costs, of care, in the first place, there would be a national budget for health care expenditures, and that would be allocated among the various states and localities and also among the sectors of medical care. The physicians on the one hand, the hospitals and other types of medical care. There would also be other ways in which the costs would be controlled, chiefly negotiation of the charges of hospital in the form of budgets in advance, and negotiation of fees with the doctors, as Mr. Fine has already indicated.
And some of these organized, prepaid group practice programs of medical care?
I'll have to ask for a quick answer on that.
There would also be those, and they have proved to be very cost-effective by cutting down hospitalization, which is the most expensive kind of care.
All right, now we'll go to Mr. Rusher for some questions to Mr. Seidman.
Mr. Seidman, are you familiar in general with the Veterans Administration Medical Care Program?
I'm not an expert on it. I know something about it.
Are you content with what you know? Do you think it successfully controls costs? You know that it is a totally federal program and totally cost-controlled.
The Veterans Administration Program, I think, comes very close to the British system of a national health service for veterans. It's not a program which I particularly advocate. I don't happen to know the cost figures for the Veterans Administration.
Let me help you
on
that.
It's not the program that I'm proposing.
I think it is very close.
It is a program which involves the government owning the Veterans Administration facilities, employing the doctors. It's not the program that I'm advocating.
Yes, and just for the record, the costs under that program, which are thoroughly controlled by the government of the United States, according to a study of the National Academy of Sciences, are 20 to 50% higher than would be necessary for efficient operation of the program.
Efficient operation of the program?
Yeah.
And I would like to know whether the tremendous costs of other hospitals in this country, the private hospitals, the community hospitals, and so on, are not also very much greater than would be required.
Let's find out in the case of the New York City public hospitals and compare them with some national figures. Would you care to guess what in 1975 the per capita Medicare expenditure was for the New York City public hospitals, which are totally public-owned and controlled?
The public hospitals are the hospitals in this country which have to take the most difficult cases of the poorest people with the worst medical conditions, and if their costs were not higher than the costs of other hospitals, I would be very much surprised.
You are right on the money. Although just a minute ago you were casting aspersions upon the performance of the private hospitals, so I thought that you would be interested to see.
I was not casting aspersions on the performance of the public hospitals. I was saying why their costs should be expected to be higher.
The figure for the New York City public hospitals, for the record, was $1,032 per capita, as against $590 per capita in the nation at large.
And that's because the sickest people, the poorest people with the worst conditions
Poor
go
people
into
don't
the
get any
hospitals.
sicker than rich people.
Yes, they do.
No.
The figures, all the statistics will show you.
And they all die.
All the statistics will show you, Mr. Rusher, that poor people do become very much sicker than rich people. And it ought not to surprise you.
I think that the medical care... Well, let's take some very poor people indeed, the American Indians on reservations, another totally federally controlled program. Are you proud of that as an example of medical care?
Mr. Rusher, you're asking me about programs with which I am not thoroughly familiar.
Well, let me
but again, if you're going to tell me that the costs are higher, it's again because the Indians do have very, very low incomes, and they do have much worse
I wasn't going to
health
tell you that.
conditions
I was
than
going
the
to
rest
tell
of the
I wasn't going to tell you
population.
the costs were higher. I was going to tell you that the costs were totally government controlled, and that the American Indian medical program is one of the most notoriously poor in the United States. You know, I should think a
Now,
person
I don't know
who is
that-
as interested
I don't
as you
know
are
that-
in further, just a moment please, as interested as you are in further medical care for the American people, would inform yourself a little better about the Veterans Administration program, which you don't know about, and the Indian program, which you've only barely heard of. Why don't you go out and find out what a mess the government you want to rely on has made of the programs that are directly under its care?
In the first place, Mr. Rusher, I didn't say I know nothing about these programs. I do know something about these
tell us
programs.
something about them.
I know that the veterans would not be getting the care that they do get if there were no Veterans Administration hospitals, and the Indians would not be getting the care that they do get if there were no hospitals in the Indian reservations.
I don't know about that. They might be getting, I'll tell you this, they might be getting care that was much better related to the costs of the care and to what is delivered for that cost.
Do
they are getting in the case
you
of the
know
American
any
Indian
private
program.
hospitals that are carrying on the kind of programs that the Veterans Administration is for paraplegics and others who have been badly injured in the Vietnam and other wars? I don't. And the reason for that is because it's the most expensive kind of care, and hospitals try to avoid that kind of care.
So that your bottom line is that
their
you
own
will,
incomes.
for the only time in the history of the government of the United States, when it takes on what you would consider apparently a fairly easy problem, it is going to solve it very expeditiously and very economically.
No, I say that when the government takes on the problem of
Quick
making
answer
sure that we're going to provide care for all the people of the United States, that we're going to get better care for the country
And
as
the
a
cost-
whole.
Mr. Rusher, excuse
And
me.
a lower
Thank
cost.
You. Ms. Butler, one last question for Mr. Seidman.
Mr. Seidman, isn't this national health insurance plan going to result in a tremendous increase in costs?
No, it is not going to result in an increase in cost. To the contrary, it's going to result in lower costs than any other plan would, or than continuing the present system. All we have to do is to look to our neighbors in Canada. 10 years ago, they had a cost as a percentage of the gross national product approximately the same as ours, 7%. 10 years later, with national health insurance in Canada, it's still 7%. In the United States, it is now 9%, and as others have said, going through the roof.
Mr. Rusher, one last question for Mr. Seidman.
Mr. Seidman, I understand that elderly populations are naturally much more expensive to care for. People over 65 have about 4.5 times as much medical care and hospital attention as people under 65. What about the problem presented by two areas of the United States where the medical allocation under Kennedy-Corman is going to be different, obviously? There'd have to be more if one population was substantially older, say Florida, than the other, some state where it was much younger. Do you see any problem there?
I do
I'll have
not
to
see.
ask for a
I
brief
do
answer.
not see any problem. It is perfectly possible to get the information which will make it clear that the area
And there
with
would be
more
no
elderly
political-
would require
Mr.
a
Rusher.
larger allocation.
All right, thank you.
All right, thank you. Thank you, Mr. Seidman, for joining us on that. Ms. Butler?
We've seen that the current medical industry squeezes us for money and then doesn't deliver. Kennedy-Corman will change all that. As you're listening to our opponent's case, ask yourselves these questions. Do they really care that people in this country can't get medical care when they need it? Will relying on methods that haven't worked in the past solve today's problems or tomorrow's? Are they really aware of how much you and I are spending for medical care and how little we're getting for our money?
For those of you who may have joined us late, Ms. Butler and her two witnesses have presented the case in favor of tonight's question. Should the federal government guarantee comprehensive medical care for all Americans? And now for the case against, Mr. Rusher, the floor is yours.
The problem of rising medical costs is a real problem. Thanks to the wonderful advances in medical science in recent years, medical care is inevitably more expensive than it used to be. In addition, unfortunately, the government, by pumping enormous sums of money into the system on terms that actually rewarded wastefulness, has made the situation infinitely worse than it would otherwise be. And that is exactly why the Kennedy-Corman Bill is not the solution to the problem. It's a relic of the days when people thought that the quick and easy solution to almost any problem was to turn it over to the government. In recent years, we have learned the hard way that government intervention often just makes matters worse and practically always makes them more expensive. The solution, as I'm sure you already sense, is not more government intervention, not government controls to try to clamp a lid on the cost the government's own expenditures are forever driving up. There are far better ways, and to tell you about them, I call first on Mr. Walter McClure.
Mr. McClure, welcome to the Advocate.
Mr. McClure is a health policy analyst with Interstudy, which is a medical systems research group based in Minnesota. Mr. McClure, what, in your opinion, is the basic problem in the field of health care in America today?
Mr. Rusher, there are many problems, but I think the overwhelming problem is cost. Costs are rising at such a savage rate that is really threatening our ability to assure adequate health care and health insurance to all Americans, especially disadvantaged Americans. Now, not only is it threatening our ability to provide adequate health care, it is also threatening other social priorities, assuring adequate food, adequate housing, adequate education, welfare, jobs. The cruel thing about this is that there is no evidence that we are getting more help for this vast medical care expenditure. There is substantial evidence that we could do as well, spending less.
But doesn't the Kennedy-Corman Bill solve the problem of rising medical costs?
I doubt that. It seems hardly to me a serious proposition to take a badly behaving industry and propose to turn it into a giant bureaucratic public utility, entirely financed, regulated, and controlled by the federal government as the solution to cost containment. Now, the government has no track record on such things, but they do say they are going to set these regional lids, and so let's try it out. What happens when the system is glutted by the worried well coming in to collect their free care?
This is the British experience. Okay, go ahead.
Who are coming in to collect their free care. Now, expenditures begin to rise above the ceiling. What can the government do but slash doctors' fees, begin to close hospitals, and start to stand the patients in line? Now, these patients standing in line and these angry doctors and these upset hospitals are not going to be sitting on their thumbs. They are going to be applying heavy political pressure, and what will the government do against that kind of political pressure? It will do what every wealthy country has done. It will cave. It will raise the ceiling, and it will then deficit spend or add new taxes in order to support this supposed cost-contained system.
Is there an example of government control that might give us some guidance here?
Well, I think your examples of the Veterans Administration and the New York City hospitals are excellent examples. I would simply point out in the meantime that this system will be heavily bureaucratized as the government tries to do whatever it does, and that health care dollars will not be advocated by reasons of efficiency or even by reasons of health need. They will be advocated by the most powerful political lobby, and I suggest to you the abortion issue.
If medical costs can't be held down by something like Kennedy-Corman, is there a solution?
Yes, I think the real solution is to begin to introduce into this badly behaved system effective competitive forces and consumer choice. Now, for example, the airline industry, which for 30 years was totally regulated and price controlled by the federal government, decided to introduce a little consumer choice and competition last year, and suddenly discovered that we could reduce the price of airfare to Europe by almost half. The same kind of medicine would be extremely good for our healthcare system. In our present system, there is no reward for either consumer or provider to be efficient. If care is totally free, it makes no difference whether I go to the most expensive doctor or the most efficient doctor. If I am an efficient doctor and I avoid unnecessary hospitalizations and I avoid unnecessary tests, I am penalized. Now, the answer to this problem, it seems to me, is for government to create some competitive pressures so that efficient doctors can organize health care plans which will compete against each other in conventional insurance, and if a consumer goes to that efficient set of doctors, agrees to do that, then he gets a lower premium and more coverage. That kind of incentive rewards the consumer for seeking efficient providers, and it rewards the efficient providers because they get the patients. There's a lot of evidence that that might do a lot better than free care from the government.
Thank you. Well, we'll go. No, come back. Please stay with us. Now we'll go to Ms. Butler for some questions for Ms. McClure.
Mr. McClure, you mentioned the VA system. I hope you're not suggesting that the Kennedy-Corman Bill is embodying that kind of a system, because we know that Kennedy-Corman would use the same private doctors and private hospitals that exist today.
Ms. Butler, what I am suggesting is you have an example there, one of the few examples that we have of a medical care system which is totally under federal control. Now, I agree with you. The doctors are employees of the government. But let's not kid ourselves. Whoever pays the piper calls the tune.
Yes,
you can call it non-government medicine if you like.
Thank you. You've also expressed the concern that under the Kennedy-Corman proposal, people will consider their health care free because it's paid by the government, and that they will seek care wastefully and unnecessarily. Now, I find it very difficult to understand how anyone likes standing in line in the first place, and particularly how someone is going to seek unnecessary care. It's not my experience that people go to the doctor when they don't need to. However, Kennedy-Corman limits expenditures by doctors and hospitals and other providers, so won't they be obligated to educate patients about how to use the system?
My feeling is that when doctors find that they are paid by the government, they will consider themselves working for the government, not the patient. And there is a fair amount of evidence of bureaucratic systems that that's what happens. Now, as for patients using free care, I would just ask you, perhaps you've had an experience in your family, or perhaps some of the viewers have had experience, when you get in the hospital and it's all covered by Blue Cross, do you really worry about the expense? I don't think so. In other words, it's not that people are rushing to get medical care. It's simply that there's a spare no expense mentality created where nobody worries about the cost. When it's all covered, why worry about what it costs? You like carpet on the floor, TV?
So you're really suggesting the elimination of private health insurance, it sounds to me. Let's talk a little bit about the problem of cost the cost problem that you acknowledge. In order to control costs, wouldn't you agree that it's better to budget in advance, require hospitals and doctors, group practices to determine in advance what their costs are going to be, and then to be forced to stick to that budget?
I think that the best way we have of containing costs that is proven in this country is an effective competitive system. We do not have an effective competitive system in our present medical care system. That is the reason we are having the problems. I entirely share with the Kennedy-Corman people their objectives of assuring all Americans adequate health care, adequate health insurance at a reasonable cost, sensible, relevant to our other priorities. It is the means that I disagree on. I simply find it unbelievable that the solution to this problem is to turn the whole thing over to the government. That sounds like we've learned nothing in 30 years.
Fine. Let's talk a little bit about competition, Mr. McClure, because I think that's the real problem in your proposed solution. Isn't it true that because patients are not the real consumers of medical care, that giving them any kind of purchasing power doesn't provide the kind of competition you're talking about? And that's because it's the physician who controls the use of medical services. In fact, doctors generate about 80% of the medical care costs. It's the physician that we have to be controlling and not the patient. The physician is the gatekeeper, but he does things with the approval of the consumer or the patient. The patient must approve what is done. You're suggesting that patients make those kinds of decisions about what a physician tells them? If I don't want what a physician recommends, I go to a different doctor. What do you do? I'm afraid that most people don't feel themselves sufficiently sophisticated to one-up their phison, and they certainly... Are you saying that the government should second-guess every... No. Let me answer. May I answer your question? I'd like to ask you one final question, and that is that the Kennedy-Corman proposal is will change the behavior of the physician by imposing that kind of fixed budget, and it will be the physician's responsibility to allocate medical resources according to that fixed budget.
I certainly
Isn't that
agree
so?
that it will change his behavior. He will now work for the government instead of the patient.
Thank you. Mr. Rusher, another question, please.
And if anything that Mr. Fine described about the contents of the bill is correct, he is also going to have a weather eye cocked on his local medical society, isn't he?
Well, that sounds correct.
We are going to have,
Only
in other
one
words, a
question,
medical
Mr.
bureaucracy involved here.
I think that is what generally happens when government tries to take over or regulate an entire industry.
Thank you. Ms. Butler, one more question. Please stay with us, Mr. McClure. He's promised to stay for one more question.
Well, I'd just like to know if you favor co-payments and co-insurance upon the patient, and isn't that really, once again, putting the burden on someone who does not have the sophistication or the actual ability to make these choices?
Ms. Butler, I may not be the best judge of medical care, but I don't think that there's anybody I'd rather have that make that decision for me, and I give that right to all American people. I would rather spend my own money for the medical care that I want. I do not want the government to take my money away in taxes and say, this is the medical care you will get regardless of whether you want it or not.
Thank you. I'm sorry, Ms. Butler. All right, Mr. McClure, now you can go. Thank you for joining us on The Advocate. Mr. Rusher.
I call as my next witness Congressman Philip Crane.
Welcome to The Advocate, Congressman Crane.
Mr. Crane is congressman from the 12th District of Illinois, the northern suburbs of Chicago, and is a member of the Health Subcommittee of the House Ways and Means Committee. Congressman Crane, what, in your opinion, is the worst single feature of the Kennedy-Corman Bill?
I think the worst feature of the Kennedy-Corman Bill is the human suffering that will inevitably attend politicization of medicine. And I think we have examples to illustrate that point. When you have politicians making the determination about how you will allocate scarce resources, in this case public money, you're going to have decisions that will be based on factors other than the immediate concern of the need of patients who are ill. We have examples. A number of us visited the British National Health Service, and while our friendly adversaries here would endeavor to draw some fine distinctions between national health insurance and the National Health Service, there are certain similarities. The similarities involve the political judgments made. And in the British Health Service, we had an example while we were there on the front pages of the papers of a woman who needed heart surgery, and they inevitably had to ration the service to guarantee free service to one and all. The woman got an appointment 9 months ahead, and she showed up for her appointment. They had limited bed space and facilities. They rescheduled her. 3 months hence, she came in that time, inadequate heart surgeons available. They rescheduled her a third time, and they called her the day before a third appointment to reschedule her again, and she died at home. And I think that's the kind of phenomenon that inevitably is the result of allocating those dollars based on political judgments rather than perceived needs by individuals.
Her lack of a doctor was more of a problem to her than her lack of sophistication, to use
Absolutely.
my opponent's term. What other costs are there? You've spoken of the cost of human suffering.
Well, I think from a realistic point of view, and I'm speaking now from the political perspective, you're talking about dollar costs that are astronomical. In fact, the additional dollar cost of Kennedy-Corman, on top of what the government is already spending on health care in this country, is approximately $130 billion. Now, that would represent an immediate 25% increase in every American's taxes. And you saw what the Congress did in response to the 5% proposed tax increase under Social Security. I didn't vote for that, but my colleagues on the other side of the aisle did, and they've been scrambling ever since to go back and repeal that action in the face of voter antagonism.
Rushing ahead just a bit, since time is short, we heard from both of the witnesses on the other side, particularly Mr. Fine, the great problem of the lack of coverage for whole large categories of Americans who only had insurance if they were run over by buffaloes and things like that. Would you tell me, please, how serious is the problem presently of lack of coverage, and how best could it be solved?
Well, I think any humane person would say any single individual who's not covered constitutes a problem. On the other hand, what you're realistically talking about is roughly 6% of the American population that has no coverage at all. And that's about 12.2 million people by a recent survey. And I would only argue that you don't throw out the baby with the bathwater. There are ways of addressing that problem, realistic ways that can be supported financially, and without imposing the incredible kind of taxation that's contemplated under this measure.
And without charging $130 billion.
Exactly.
Lastly and briefly, is there any other defect to the Kennedy-Corman Bill or problem that you see with it?
Well, there's one that British physicians told us about when we were in Great Britain, and that is once you sever the connection between the doctor and his patient, and as was mentioned in earlier testimony, that physician is then working for a different provider of his income, you've lost something infinitely precious in our current healthcare system. And so there is a disposition for a rather calloused and indifferent approach to treating that patient, and I think anyone who served in the Army particularly has had some experience with the kind of solicitous treatment you're going to get from a physician or dentist in the military.
You don't take very seriously the supposed distinction between the man who is on the outside but working for them, right?
Very briefly. All right, I now go to Ms. Butler for some questions for Congressman Crane.
Yes, Mr. Crane, you've made quite a point of the experience in Great Britain. As we know, the British Health Service has been in existence since just after World War II, and a health insurance program in that country since 1912, and there are no moves whatsoever to repeal that system or to alter it. And as I understand it, the British people have overwhelmingly indicated their strong support of that system.
Is that why 1/3 of every graduating class in British medical schools immediately leaves the country, and the brain drain is now up to the 45-year-olds?
Well, as I understand it, as a matter of fact, the British system has developed a number of extraordinary medical technologies, and it's very innovative.
Oh, yes. In fact, that's a very good point you raised. They invented the CAT scanner, that device for detecting brain tumors and brain cancers. When we were there 3 years ago, the British National Health Service had purchased only one and had none on order for 50 million people. There were roughly 90 that had already been purchased in this country and 100 on order at that time. At the present time, there are more CAT scanners in the city of San Francisco than in the entire British National Health Service today, which is another one of the faults of the program.
And as, of course, I'm sure you'd be the first to point out, CAT scanners proliferating in this country have increased tremendously the problem of medical care inflation.
Well,
let's talk a little bit about the tax increase problem that you assert. You claim that we'll be adding $130 or $140 billion to the federal budget for medical care. But isn't that true that this money is not new money, but money that we're currently spending on insurance premiums, out of pocket for medical care, and we'll just be shifting the money that we already spend to a different payer, in this case the federal government? We'll spend the money more equitably and more economically.
That's the theory behind it. I think that has to be demonstrated in practice because even in the British National Health Service, there are people who are paying confiscatory levels of taxation who will not go to the British National Health Service and stand in line waiting for years to get a hernia operation. But I think in addition to that, there are many Americans, millions of Americans today, whose insurance premiums are being paid by their employers. Now, those workers are going to get the immediate impact, instead of having it paid by their employer, of a 25% hike in their personal taxes. It's an insupportable tax increase.
What is your answer to cutting the cost of medical care? We've heard that Mr. McClure favors some sort of a program of changing organization of medical care, but we haven't heard anything that you would
how much
propose.
time do we have?
Very little.
You know, we ideally should devote a whole program to alternatives and sensible, intelligent alternatives to the program that we're discussing tonight. I think the inherent deficiency of the program that we're discussing tonight is enough to reject it. There are problems that can be addressed in intelligent ways. Tax credits have been thrown out, I think, in earlier testimony as one way of dealing with it, an extension of the coverage for those limited individuals who are in the categories that will sustain potential catastrophic coverage. There are rifle shots, in other words, that can be directed at specific problems. That's what we should be jointly working on.
Sounds to me like a shotgun approach, all right, and I don't understand how that is going to solve the problem
rifle shot.
of access.
Yours is the shotgun.
Of access to care for people who need it.
Well, certainly, because we define who the people are. And that, in fact, we've worked on in committee. We had a specific case in point when we had the higher unemployment rates and the extended periods of unemployment of some of those people who, before they found new employment after they were laid off, their insurance coverage expired. They were people who fell between the cracks. We identified those people, endeavored to draft legislation to deal with their specific problem.
But that won't provide any kind of medical services in areas of the country such as rural areas and ghettos where there are no physicians that refuse to practice there.
Well, let me put that problem in perspective. We have 3,084 counties in the United States. 132 are doctor-less, and 0.2% of our population live in those doctor-less counties. Now, to be sure, that's a problem, but even Great Britain has a maldistribution problem with 30 years of socialized medicine. The Soviet Union has a maldistribution problem, notwithstanding the fact they can persuade a physician to go practice in Siberia at bayonet point.
All right, Mr. Rusher, one more question, please.
Congressman Crane, is the matter of crossover, the change of the money from one pocket to another, really the truth? Isn't it a fact that there are going to be enormous increases, administrative and otherwise, with respect to any such program that's put into effect?
Well, in the preliminary remarks by our lovely moderator here, the reference was made to the astronomical increases in the cost of health care in this country. I would only remind you that about 20 years ago we were paying 3 cents for 2-day delivery first-class mail. And now we're contemplating 16-cent first-class mail, and in addition to that, the possibility of 3-day-a-week delivery. I think there are some very distinct parallels that can be drawn between what has happened there and what one can reasonably expect from government medicine.
Thank you. Ms. Butler, one last question to Congressman Crane.
Mr. Crane, do you believe that health care is a right that it should be afforded to all Americans regardless of whether they have the ability to pay?
I think every physician who goes through medical school takes the Hippocratic oath that recognizes that he has an obligation to treat people in need. Now, we have created problems in providing or fulfilling that need. The old phrase, "Is there a doctor in the house?" for example, was a call that went unheeded after physicians started to get penalized in the courts for giving immediate care and not following up on that patient.
And I don't understand how that has any relationship to the problem of people
I'm sorry,
who
I'm
can't
going
pay
to
for
have
care.
to interrupt on that. One very brief answer, if you have one, Congressman Crane. Did you want to give one?
To that. Well, in response to your question, I would say that if you have the ideal situation, and that's Mark Hopkins' ideal teaching situation, it's a patient on one end of the log and the doctor on the other. And so in terms of fulfilling that right you've defined, it's a question of whether you have the adequate personnel and the adequate facilities, and I would argue Kennedy-Corman is guaranteed not to enable us to provide those facilities.
That's all we have time for. Thank you, Ms. Butler. Congressman Crane, thank you for joining us on The Advocate. And now let's go to our closing statements. Ms. Butler.
If we pretend that old-fashioned competition will lower the cost of medical care, we're just fooling ourselves. Moreover, old-fashioned competition can never bring medical care to everyone, and our opponents know it. Timid, half-hearted measures will never curb a bloated industry's appetite for dollars. Not when it's the doctors and the hospitals who alone decide what they can charge. Our national health insurance proposal has the strength, the imagination, and the courage to make our healthcare system truly serve us all and save us money. It will minister to our sick economy by controlling costs through a national budget for health care and through incentives that will reward doctors and hospitals not for extravagance, but for good service and economy. When our proposal goes to work, no one will ever again awake from needed surgery to the nightmare of being handed a bill he hasn't the means to pay.
Thank you, Mr. Russell.
The choice before you tonight is not a choice between health care and the lack of it. It is a choice between health care agreed on between doctor and patient and financed in a way that makes both of them conscious of the costs and health care supplied under rigid guidelines laid down by a board in Washington and financed in a way that will make everyone concerned completely indifferent to the costs. So indifferent, in fact, that a special system of controls has been specially added to the bill in a desperate attempt to keep them from going through the roof. Such controls have been tried in this country repeatedly, as you heard. They have never worked, and they won't work now. The Kennedy-Corman Bill is dying on the slopes of Capitol Hill tonight because it has been recognized by just about everybody for what it really is, a sweeping, bureaucratic bid to bring all of American medicine under central government control at a cost vastly higher than the American public either needs or can afford to pay. Don't sit this one out, ladies and gentlemen. Vote no.
Thank you. Thank you. And now we turn to you and our audience and ask what you think about the questions raised in tonight's debate. Should the federal government guarantee comprehensive medical care for all Americans? Send us your vote, yes or no, on a postcard to the Advocates, Box 1978, Boston 02134. In February, the Advocates debated the question, should the United States support self-determination for the Palestinians in a Middle East settlement? The Advocates' audience responded this way: 1,782 in support of self-determination for the Palestinians, 5,977 against. If you'd like a transcript of tonight's debate or transcripts of our previous debates, please mail a check or money order for $2 to that same address, the Advocates, Box 1978, Boston 02134. 2 weeks from tonight, the Advocates will return to debate a question of superpower diplomacy and global strategy. Should the United States reject détente as its strategy in dealing with the Soviet Union? And now, with thanks to our Advocates and their distinguished witnesses and our audience, we conclude tonight's debate.
The Advocates is a production of WGBH Boston, which is solely responsible for its contents.